So I am Carol. I'm with Santen, Canada. So a nod to our last group of panelists. Santen is a Japanese-based organization that is actually looking to invest in the Canadian market. So be rest assured that there's at least one of us that's looking to invest in the Canadian market. And we are focused solely on ophthalmology. So our topic today, as Tiana has mentioned, is National Pharmacare in Canada. And we have some intriguing and some important conversations with our panelists today. And I've been actually tasked with creating a level set on exactly what National Pharmacare is in Canada so that we have a good basis for the remaining conversations. So National Pharmacare, well, this is a hot topic right now, and it is across the headlines. It is by no means a new topic in Canada. And in fact, I actually should step back and mention, as all of you are probably already aware, we are the only nation with universal health care that doesn't have a National Pharmacare piece as a component of that. Now, this was not, it was always intentional, actually, to add National Pharmacare into our universal health care program as far back as the 1950s and the 1960s. And at that time, we had introduced our universal health care, and the Hall Commission had actually recommended that we layer in National Pharmacare following the establishment of our medical care and our hospital insurance. Priorities change and budgets are limited, of course, and of course, as we know, that did not happen. And then as we moved into the 1970s, we moved into a revolutionary era, as everybody is probably aware, in pharmaceuticals. And so we started to see great improvements in the development of pharmaceuticals, which also resulted in great health benefits and, of course, resulted in rising drug costs. And in fact, by the time we reached 1997, drug expenditures were the #2 component of healthcare spending in Canada. So of course this raises the attention of Canadians, and this raises the attention of politicians, and we looked at and saw a plethora of reports and commissions looking at National Pharmacare again, and this is by no means an exhaustive list, but it's some of the key ones. And that's led us to most recently the Casey report in 2016, which tabled 18 recommendations on National Pharmacare in Canada, which served as the basis for the Liberal Party's platform on National Pharmacare in Canada. And then from there, as you may be aware, the Budget 2018 actually established the Advisory Council on the Implementation of National Pharmacare in Canada. And so this council is really tasked with looking at economic and social evaluations of National Pharmacare programs, either within Canada that already exist or internationally. They are also tasked with making sure that there are conversations with the provincial, territorial, and Indigenous leaders, as well as Canadians as individuals and us as stakeholders. And what the Advisory Council looks like is Dr. Eric Hoskins heads this, who those of us from Ontario know as our former health minister, and then 6 academics and political figures supporting him on the Advisory Council. So the Advisory Council has actually recently published a discussion paper in June of this year, and really it looked at sort of the justification for National Pharmacare, and why we're revisiting this conversation right now is the increase in rising drug costs, as well as the fact that we don't have equal or equitable access to drugs across the country. So sort of two key things that the discussion paper is looking at. And they also look at 3 critical questions. So one of them being, who should be covered by National Pharmacare? What should be covered? And most importantly, how will we pay for it? So the first question about who will be covered, they looked at 3 sort of ways forward, one of them being a comprehensive universal coverage. So essentially this would look at everybody covered under the same plan in the same way, and this would ostensibly look at replacing the existing private reimbursement scenario. Second option looking forward would be a safety net. So this would essentially establish a threshold of, like for example, a percentage of household income above which, if a drug cost is beyond that, the public reimbursement would pick up the bill, and anything below that, the individual is responsible, or private payers. And then finally, looking at an option of closing the gaps. So this kind of looks at leaving this scenario as it is, but implementing either regulations to close the gaps or looking at additional funding to close the gaps. And an example of that might be instituting legislation that would require employers to provide public reimbursement. So the second question, what drugs would be covered? So the first two are fairly similar in that they would be suggesting looking at a formulary of essential medicines. An example of this would be the World Health Organization has a list of 300 essential medicines that are used in primary care, and that would be the basis of our formulary. Or we could look at the most frequently prescribed drugs across the country. Both of these would require a top-up from private reimbursement, and neither one of them really addresses the issue of newer, higher-priced drugs. The third approach that they're suggesting we should investigate is more of a comprehensive approach. While this would not be an open plan, it did start to look at incorporating newer, higher-priced drugs. And then in my view, of course, the most important question is how are we going to pay for this? So the discussion paper doesn't offer as many potential ways forward in this scenario. It just mainly asks the important questions about how are we going to redistribute the federal and the provincial and the private funds? Where is the patient going to come into play here? Should we be paying co-pays? Should we be paying deductibles? Should we have caps and premiums? And the other thing that they do raise is another question, which could be quite controversial, is should we be asking employers to redirect the premiums they pay on for private plans right now into the public purse? And I think probably the most important point for all of us in the room that is emphasized within the discussion paper in this point here is there is definitely a sense of confidence within the discussion paper that if we have one singular formulary that is publicly based, that the government will have the ability to drive down drug prices and negotiate lower prices. So clearly a very important consideration for all of us in the room. So again, we clearly do have a robust pharmaceutical industry in Canada, so somehow we are actually paying for our drugs. And this is just a breakdown of what our dollar spends are. And despite the fact that the Canadian Health Policy Institute does suggest that virtually all of us 36 million Canadians have either a private or a public plan, this does still show that there's a lot of funds that are coming out of pocket. So approximately a quarter are coming out of pocket, and that could mean patients who don't have insurance or patients who are paying a high premium or an out-of-pocket expense in the form of a deductible or a copay. And in terms of what our system actually looks like, we have a matrix of coverage. So I was actually, as I was researching, I was actually surprised to see that we have 70 provincial and territorial plans. We have 6 federal plans and over 113,000 private plans between 132 providers. So a matrix, and a matrix that goes even deeper. So within those 3 groupings of plans, so the provincial plans, the federal plans, and the private plans, there are even further subcategories. And they typically target special populations, except for the private plans. And then when we look at the private plans, as you've seen in the previous slide, there can be an infinite combination of plans available out there. So ultimately what this does is this equates to us that there is a huge variance, not only across the country, but even inside our individual provinces about who is covered, what they are covered for, and how they are covered. So a key focus for National Pharmacare moving forward, and how do we bridge those gaps? And then how does Canada compare? So if we look at other industrialized nations that have universal Pharmacare, that have universal health care, and also National Pharmacare, you can see that we spend quite a bit less we contribute quite a bit less to the prescription drug spends in Canada than the other members of the Organization for Economic Cooperation and Development. They're spending on average about 70% of the spends for public drugs, and we're only spending about 42%. So now you have a bit of an understanding about how we got to the current conversation around National Pharmacare. You have a bit of an understanding about what's being discussed with the Advisory Council. The discussions that the Advisory Council were having with the Canadian public have now closed. They closed in September, and they are due to provide their findings in the spring of 2019. So watch for those, and I hope that you got the opportunity to put in your input. And so now we have a number of other topics in consideration while we are looking to move forward with National Pharmacare in Canada, assuming that this passes a reading in the House of Commons.